I'll run through a few things. The outline or the agenda of my presentation is as follows. I would like to just remind us about the UHC, the definition, implications, goals, dimensions, and coverage targets. Then I'll talk about sources of health financing in Nigeria. Thirdly, I'll talk about implications of Nigeria's current health financing for achieving UHC. Four, I will spell out the constraints, the major constraints to achieving universal health coverage in Nigeria. Then fifthly, and that's the core of what I will say, I will talk about changes that are needed in health financing to move towards UHC in Nigeria. And finally, I will conclude and make some recommendations. Now, just to remind us about UHC, I've given the definition there very quickly. Everyone in the population has access to appropriate promotive, curative, and rehabilitative care when they need it and at affordable cost. And there are three major implications of this definition. One is that you have equity of access according to needs. Secondly, that you have financial risk protection. Thirdly, there is equity in financing. Then the goals of UHC are those three that they are related to the definition. The first one is equity in service use. Second one is adequate quality. And the third one is financial protection. And as we saw during the technical discussions, there are three dimensions of UHC. There is the breadth of coverage, that is who is covered. There is the depth, which is what services are covered. And then there is the height, that is what proportion of the cost will people have to still pay for. That is shown in this diagram here, which is familiar to many of you. The height, the breadth, and the depth is shown there.
Professor Lambo, if I may interrupt you briefly, please.
With a very comprehensive package, and I agree, because their package covers about 90% of the disease body. But I think they have a problem now with financing that. And then the third target is how much of the direct cost should be covered. Again, for this one, it may not necessarily be 100%, but what should be paid by the patient should be as small as possible. Now, next I talk about the sources of health financing in Nigeria. This, I'm sure, is known by most of us here. There are, depending on what, here I'm taking 6 classifications. The first one is out of pocket. Second one is tax-based revenue. Third one is social health insurance. Fourth one is private insurance, and under this there is the private commercial, and then there is the private mutual. That is the community-based health insurance scheme. Then the fifth one is donor funding, and the last one, subsidies, exemptions, and deferrals. Now I'll just take them one by one and give you a highlight of where we are. Please listen to this, because this is very key. Out of pocket. We know what out of pocket means. It means paying for service, paying for drug cost of supplies, registration fees, consultation fees, and so on. The interesting, remarkable, let me use that word. In Nigeria, 70% of the total health expenditure, almost 70%, between 68 and 69, between 68 and 70, is paid by the patients, which is saying that it is the consumers really that are funding the health sector in Nigeria largely. This one has implications because it then implies that there is a high potential that many Nigerians will be suffering from financial tax-based revenue. You know what that means? That is what government is spending, and what government is spending is coming from the various sources of taxes that you have. Again, please listen to this. In Nigeria, the proportion of total health expenditure that is coming from government is about 24% on the average. And out of this 24%, 12% is from federal government, 8% is from state government, and 4% is from local government. I will tell you the implications of this later. Now, most of the spending that is done by the state and local government on health is coming from what they get from the federation account. And they get the money from the center, but the center has no control over how this money is spent. That is a problem. And something to note here also is that you remember there is the Abuja target of 15%. They agreed here in Abuja in 2001, I guess, that 15% of the government expenditure should be devoted to health. And right now, you know where we are. We are only around 6%. Okay, and that 15% is for all levels of government, central, state, and local government. But on the average, we are at 6%. Next is health insurance. I'm proud to say that we launched, although our health insurance scheme has been mentioned since 1962. It was in 1999 that the Act was enacted, but serious implementation did not start until 2005. And indeed, we started that with the former sector program. One very big problem that we have with the Act establishing the National Health Insurance is that it is made optional. It is not made compulsory. And that is one of the reasons why we are snailing, if there is any word like that, in implementing NHIS. Because as of today, the former sector program covers largely only federal public servants and their families, and only about 3 million are covered. The states and local governments, as well as former private sector workers, are not yet covered. And there is very limited coverage with private health insurance plans. Now, I think the last bullet is very important for us to know, that prepayment contributions to total health expenditure in Nigeria is only about 3%. I hope you are noting these percentages because they speak volume. The next is community-based health insurance. What I can report as of today is that pilot schemes are ongoing in many parts of Nigeria, particularly in Lagos and Kwara states, and FCT. And I would like to also announce that there is a scheme being operated in my village, and is doing very well by the grace of God. There is no policy and legislative framework for the schemes yet. I think this is one of the things to note, that there is need certainly to have a policy framework and legislative framework for this. Now, the contribution of community-based health insurance to total health expenditure is almost zero, okay, because there are small pools here and there, and therefore it's nothing to write home about yet. But it has a potential if the right thing is done. Then next is donor funding. We are lucky in Nigeria in a way, lucky and unlucky in another. I don't have the time to go into this. We are not heavily dependent on external funding. It's only 4%. There are countries where it's as high as 40%. But Nigeria is 4%, but that 4% certainly is too low. And the sources are from loans and grants from multilateral institutions like World Bank, African Development Bank, bilateral sources, foundations like Gates Foundation is putting a lot of money into health, and the global health initiatives like Global Fund and so on. Now, the major challenges of donor funding include ineffective coordination, difficulty in tracking donor resource flow, and so on and so forth. Then the last one in terms of sources is subsidies and exemptions. You heard what the governor of Ondo was saying this morning. That will fall under this. But a prominent one we are implementing, or we have implemented, is the National Health Insurance MDG Debt Relief Grant for the provision of free MCH services for the very poor, and it's being done in some selected states and local governments in those states. There is this sure PMCH implementation in the health sector. And the third one is very important, that some states, like you had Bauchi say, and some other states, they have policies and programs aimed at providing free MCH services, and this is very commendable. So those are the broad categories of health financing in Nigeria. Now, if you listen to me carefully, we can now talk about the key features of health financing in Nigeria. And this is very important because this will now tell us in which direction to go if we must pursue universal health coverage vigorously. The first one is that it is the total health expenditure is inadequate as a proportion of the GDP or even per capita health expenditure. I'll talk about this later. Then there is low level of public health. There is total health expenditure and there is public health expenditure. Total, total health expenditure includes public and private. Then public is what the government is spending. And the government health expenditure is very low. It's supposed to be about 5% of the GDP, but in Nigeria it's only about 1%. The per capita expenditure on health, per capita public expenditure is only about $10, and what is recommended by WHO is $34. Actually, it's gone up now. And the total health expenditure as percentage of total health expenditure as a percentage of total government expenditure, like I've said earlier on, is only 6%. There is low state government and local government health spending relative to that of the federal government. Like I said, federal government is putting in about 12%, state is 8%, local government is 4%. Then there is very high, outrageously high, out-of-pocket payment of above 60%, compared with a threshold of 15 to 20%. There is very low coverage with risk pooling mechanisms. And so if you take all this into consideration, and it will be clearer later, you will see that Nigeria is certainly at a very initial stage of transition to universal health coverage. Continue. Also, some of the key features: inadequate funding from external sources, inefficiencies both allocative and technical, pardon my jargon, in both public and private health sector. And then there is ineffective health services. That is, the health services not achieving their... I will read through this conclusion, and I hope I will be... Enhanced data equity, if access to, in access to, as well as in financing health services in Nigeria. Now, the next one is equally important. Even if you have the money, what we are saying here is moving towards universal health coverage goes beyond health financing, and I think it has been mentioned either in the minister's speech or somebody's speech earlier, maybe one of the partners. It involves other aspects of the health system in order to ensure availability and access to quality, capital quality, underlying quality health services. This one is a recommendation. There is need for a broad-based development of a vision and comprehensive strategy for addressing progress towards UHC, as well as the establishment of a multi-sectoral national task force to steer the UHC agenda, including the monitoring of progress. What I need to underscore here is when we are seriously embarking on UHC, there is need to monitor how far we are going, report on this, and do things rightly. Just 30 seconds. The next one is that the fast-tracked amendment of the 1999 NHIS Act and the repositioning of NHIS, because NHIS has a critical role to play. But we cannot play that role with the current NHIS Act, particularly since it makes insurance just optional. We have to make it mandatory before we can move forward. Next is that local evidences should be generated and used, and international evidence should also be used as a guide in our journey towards UHC. Thank you, Mr. Chairman. The last one I think I want to say...
You wanted only 30 seconds.
No, this is very important, sir. is that the passing and Senator Okowa, thank you very much for this. Thank you for all your efforts. Is that the passing of the National Health Bill into law has been very long overdue. This was drafted in 2004. That's about 10 years ago. Its speedy passage will mark the beginning of our sincere journey towards universal health coverage. So I plead
thank you very much.
that there is a speedy passage of this important bill. Thank you very much.
Thank you very much.